My name is Kirk Geyer, and I'm the General Manager of Biomedica Diagnostics. On behalf of the Biomedica team, it's my pleasure to welcome you to our series of scientific discussions with key opinion leaders in the field of thrombosis and hemostasis. I hope that you will find these topics both informative and stimulating. At the end of each video, you will find an email address where you may send us your comments and opinions. We would also appreciate your suggestions for future topics that may interest you. Now, on behalf of Biomedica, please enjoy.
Hello and welcome to Coag Conversations, an educational series sponsored by Biomedica Diagnostics of Windsor, Nova Scotia, Canada. I'm George Fritzma, faculty at the University of Alabama at Birmingham School of Medicine, Division of Laboratory Medicine, and proprietor of the Fritzma Factor, your interactive hemostasis resource, where we exchange current information on coagulation mechanisms, clinical observations, and the role of the laboratory in diagnosis and management of disorders. We welcome you to our three-part series, Managing the Direct Oral Anticoagulants, commonly named the DOACs. Our guest is Dr. Karen Moser, Medical Director of the Hemostasis and Thrombosis Laboratory at ARUP Laboratories in Salt Lake City, Utah. She's also an Associate Professor of Pathology at the University of Utah School of Medicine. Dr. Moser received her medical degree from St. Louis University and served her residency at the University of Utah School of Medicine. She also served a fellowship in hematopathology at the University of Utah School of Medicine. She's certified by the American Board of Pathology in anatomic, clinical pathology, and hematology. Her research interests are in laboratory hemostasis and thrombosis testing and medical education. Part 1 is now available on our Biomedica Diagnostics website and is entitled DOAC History and Clinical Use. Today, we address Part 2, Measuring the DOACs. Dr. Moser, please first delineate the mechanisms of the individual DOACs.
So in addition to talking about how the DOACs act on coagulation factors on our coagulation cascade diagram, I'd like to share a memory tool that helps me remember what these different drugs do. If you look at their generic names, dabigatran, rivaroxaban, edoxaban, apixaban, they tell you what they do. Dabigatran, the direct thrombin inhibitor, is an AT, which I think of like against thrombin in its name, and the direct 10A inhibitors all have the suffix XA or 10A ban. So rivaroxaban, apixaban, edoxaban all directly inhibit factor 10A.
Thank you. That's very helpful. Let's go on to talk about lab testing, and let's start with some of the specific assays that have been developed for measuring the DOACs. If you would, please go into some of the what's happening with the specific laboratory assays.
Okay. We have a few available, and as I mentioned in our last session, we in the laboratory were kind of behind the 8 ball here in developing these once the drugs were already on the market. So we've been working to make these available and to learn more about the best way to measure these drugs. Even though they don't require monitoring per se, sometimes we need to make a measurement to guide clinical decisions. So I'll start with our specific assay to measure direct 10A inhibitors. As we saw in our last session, rivaroxaban and apixaban are gaining market share. And I can tell you those are the most commonly used in my academic setting. So this is something we get questions about pretty often. The chromogenic anti-10A activity assay is the same parent assay that we are familiar with from monitoring unfractionated heparin and low molecular weight heparin. So the basic mechanics are the same. The key difference here is the calibrator that we choose to use. So we can calibrate this parent anti-10A activity for unfractionated heparin, for low molecular weight heparin, or for the direct 10A inhibitors, rivaroxaban, apixaban, and edoxaban. So we have to choose an appropriate calibrator set for the drug we're trying to measure. I have just a quick review diagram here that I'm sharing, showing how the chromogenic anti-10A activity assay works. Basically, we're measuring the ability of 10A inhibitor complexes with 10A. Well, let me back up. We're adding in a residual excess factor 10A. And if there's a direct 10A inhibitor present, it will complex with factor 10A in the assay mixture. But there will be some residual factor 10A as well. We're measuring the ability of that residual factor 10A to cleave a chromogenic substrate and generate a signal that we measure as light. And then we're comparing the signal to a standard curve to get the drug concentration in nanograms per mil. So there's an inverse relationship here, which is a little bit tricky to think through. If there's lots of residual factor 10A, that means there isn't very much drug around. All that residual factor 10A will cleave the chromogenic substrate, and there will be lots of signal. So lots of signal means not a lot of drug. And the converse is also true. Only a little bit of signal means that there was quite a bit of direct 10A inhibitor present. Not a lot of residual factor 10A to cleave the substrate and generate signal. So an inverse relationship. The interesting thing about these quantitative tests is that many labs have experience, as I said, with the anti-10A activity assay. So you would think these tests might become more widely available in the future. I think the major thing holding laboratories back at present is that there are limited FDA-approved calibrator materials. So most laboratories are still faced with creating lab-developed tests if they want to offer a chromogenic anti-10A activity to measure rivaroxaban, apixaban, or edoxaban.
That's an important issue. And is that the way that we measure the direct thrombin inhibitors as well?
No, the mechanism is different. Makes sense, right? Because the drugs work in a different way. So for dabigatran, the oral direct thrombin inhibitor, we have a couple of choices. The dilute thrombin time or eccrine-based chromogenic assays have been described and are available to quantitate dabigatran. These are less widely used, probably owing to the fact that fewer patients are using dabigatran than direct 10A inhibitors, but these assays are still available from some reference laboratories. I should also mention that quantitation of DOACs by liquid chromatography and tandem mass spectrometry is available to quantitate all of the DOACs. So LCMS-MS is another method of quantitation. It's only available in a few reference laboratories. Not everybody has that equipment sitting around, as you might imagine. And so this method of DOAC measurement has an extended turnaround time. It's not really practical for any immediate patient care decisions that a clinical team might be trying to make, but it could be a good option for less urgent measurement needs. So if you are asking the question, if I have a patient who maybe is at an extreme of weight or has impaired renal function, and is that patient in the expected on-therapy range, LCMS-MS might be a good choice in that scenario.
Okay, now many laboratories either have not set up the specific anti-10As or the direct thrombin inhibitor assays. Is there another way that they can get the information that they need, which often comes up in an emergent situation?
I guess my answer to that is sort of. This is where we as laboratorians went when the DOACs were first introduced. We said, gosh, we have lots of experience with PT and PTT and thrombin time. We are so good at doing clotting times. That's what we're about. We bet we can use these clotting times to measure DOACs as well. they work great for heparin and warfarin, so let's give it a go. But over time, we learned that there definitely are some significant sources of variability and some unpredictableness, if you will. I don't even know if that's a word, but it's the response of different clotting times varies quite a bit by reagent and by drug. So let's talk about a few details instead of just staying up here in the clouds with a real general claim. So I have a few slides just to highlight what I'm talking about here. First, let's think about the PT. So the prothrombin time is not particularly sensitive to dabigatran, but it's somewhat more sensitive to direct 10A inhibitors. And there's kind of a rank order list of sensitivity. Rivaroxaban tends to show more effect than edoxaban, which shows more effect on the PT than apixaban. And most PT reagents are not particularly sensitive to apixaban. Let me highlight here that there is significant variability between different PT reagents. And here's an example of what I'm talking about from the literature. So all the different colored lines on this graph are showing different commercially available PT reagents. And for a given degree of rivaroxaban concentration, there's quite a swing depending which reagent a laboratory is using in terms of how prolonged the prothrombin time might be. It's something to be aware of as a medical laboratory scientist and as a laboratory director. What are the properties of your particular PT reagent? And how does it play with these different direct 10A inhibitors? Knowing that can really help you counsel clinical colleagues as to whether or not you may get a qualitative sense of whether drug effect is present or absent using your specific reagent. But again, it's a qualitative assessment. Doesn't give us any information about how much drug is there, just are we able to pick up an effect? And that really depends on the particular reagent in use. Same concept for PTT. So the PTT is relatively more sensitive to dabigatran, but even a normal PTT is not sufficiently sensitive to exclude on-therapy dabigatran levels. So if you get a prolonged PTT, that would suggest there's some dabigatran effect present. But if the PTT is normal, it's hard to say either way if there's drug effect. There still could be on-therapy levels of drug. PTT is not particularly sensitive to the direct 10A inhibitors, weakly sensitive to rivaroxaban with most reagent studies, and it's pretty insensitive to apixaban. The other thing that I should highlight here, that I actually put on my previous slide, but I want to say clearly now, is that the PT and PTT are insufficiently sensitive to completely exclude the presence of DOAC, even if both are totally normal. So the way I think of these clotting times is they're great tools for giving us a clue that there could be some drug effect present if the clotting time is prolonged. But if it's normal, we're still left wondering, gosh, is there drug or isn't there? It can be hard to tell. The last routine clotting time that I should mention is the thrombin time, which, as you might expect, isn't particularly useful for saying anything about direct 10A inhibitor effect, but is particularly helpful in describing the presence of direct thrombin inhibitors like dabigatran. Thrombin time tends to be really sensitive to dabigatran, and it will give marked prolongation. We're talking greater than results here, even at relatively low drug concentrations. So thrombin time, when it's normal, is a great clue that there isn't significant dabigatran effect present. But if the thrombin time is prolonged, all we can say is that there's drug effect present, but whether the concentration of dabigatran is low or beyond the on-therapy range, we have no way to know. It's very sensitive to dabigatran.
I started an argument on Pritzma factor a little while back when someone had asked whether they could detect the anti-10A DOACs using heparin calibrators. And I first thought, well, one of my colleagues said, no, you can't get away with that. And then I came back and said, but we're doing it that way at UAB. So can you comment on just operating using the heparin-based curve?
Yeah, so I think that's a common strategy, and it intuitively makes sense, right? The anti-10A activity assay, no matter what you calibrate it for, it's the same parent test. So it's going to be able to pick up anti-10A effect, even if it's from a drug other than the one you calibrated for. So there has been interest in using anti-10A activities calibrated for low molecular weight heparin that are more widely available and often available on a 24-hour-a-day basis with fairly rapid turnaround time in hospital laboratories. Could you use that qualitatively? So if I have a patient that's on apixaban, say, and I submit their sample for anti-10A activity calibrated for low molecular weight heparin, if there's detectable anti-10A activity, can I conclude that there's some drug effect present? And I think we have data to say that you can. So not every anti-10A activity assay available on the market has been studied, but some have, and they appear to be able to detect direct 10A inhibitors. Now, I'll caution you that, again, you have to use that assay, the low molecular weight heparin calibrated assay, in a qualitative way. Even though you get a number, the number isn't really meaningful for an amount of rivaroxaban or apixaban because it's not calibrated for those drugs. But I think it is safe to say that if you have detectable anti-10A activity, that implies the presence of a drug. The quantitation is totally goofy if you're using a low molecular weight heparin assay. And I would add to that sometimes that can be an attractive option if you're trying to make a quick clinical decision. Again, the low molecular weight heparin calibrated assays are far more available than the DOAC calibrated anti-10A activities.
We have a mutual colleague who said, what's the big deal? It's easy to make a laboratory developed test. And the answer to that is, well, yes, in a large facility, but what about us in smaller facilities? It's not so easy. I want to touch the third rail briefly here and ask you, do you think the FDA is going to come around to approving some of these calibrators and controls?
I think with time that could be the case. I'm aware of one apixaban calibrator that has been approved by the FDA. So the ball is rolling. This is starting to happen. I think this comes back to the laboratory sort of being behind the curve as these DOACs were rolled out. So they're great and new. They don't require laboratory monitoring. There wasn't a process where a companion diagnostic test was developed in parallel with the assay. So we've been learning and developing as the drugs are in widespread clinical use. I know that many of the calibrators available are for research use only, and there are data to suggest they work well. My hope would be that eventually more calibrators would be approved by the FDA, but it's a long road and it's been slow coming. I anticipate that the COVID-19 pandemic probably didn't help matters any, as the FDA has been a little bit busy for the past few years.
That's for sure. And one last question on this subject. You have briefly touched on some of these questions, but what are some of the reasons for even doing laboratory measurement of the DOACs?
Absolutely. We always want to know why we're doing something, not just making measurements willy-nilly and hoping somebody knows what to do with it. So we've alluded to that sometimes in patients that come to the hospital emergently, if there's suspected overdose, if there's life-threatening bleeding, or if there's a need for an emergent invasive procedure where we just can't wait for DOAC effect to clear, we may want to make a measurement to help guide the next step. How much bleeding would we expect if we had to take this patient to the OR? Should we consider some reversal strategies if there's severe bleeding? The other use case that I alluded to is in patients where there might be altered metabolism of the DOACs. Some physicians might want to make a measurement to ensure the drug level is within expected published on therapy ranges. So these could be patients with altered renal function or extremely high or potentially extremely low weight, or maybe with some anticipated drug-drug interactions that could alter metabolism. Now, I should caution that there aren't really guidelines for adjusting DOAC dose based on a laboratory measurement. So if a physician gets a result that's outside of the expected on-therapy range, there's no guidance that says, oh, just bump up the dose or pull back the dose. Really, the only course left to them is to choose an alternate anticoagulant. So again, this is different than the paradigm we're used to working within for heparin and warfarin, where we give a dose, we make a measurement, we say, oops, too high or too low, we adjust the dose and we measure again until we get right within that therapeutic range. Not so for the DOACs.
Given the number of clinical applications for measurement, it does seem like we would be doing it more often. So I think that's a very insightful comment that you've given us. Dr. Moser, thank you for your expertise, and thanks to our audience for participation in this section of our COAG conversation. We encourage your questions and comments. You can post them to an email address or to the website at Biomedica Diagnostics. And this concludes today's conversation. Please join us next month as we continue our discussion and we focus on DOAC risks and their reversal. Thank you.